Okay, so thank you for that very nice introduction, and it is good to see everybody here. And I assume I'll have people watching virtually as well. All right, so my first talk is breast MRI in the newly diagnosed breast cancer patient. I don't have any conflicts of interest or financial disclosures, and this is a SAM session, so you may get like hints from me about what these SAM questions might be, because even though you don't have to get them right, it's kind of nice to get them right, isn't it? Okay, so what we're going to cover in this talk are the uses of breast MRI in the cancer patient, benefits and controversy. We'll go over some of the discussion about whether or not to use it, and then we'll finish up by talking about ways to optimize use. Breast MRI is the best way to determine lesion size. Best way, MRI, better than ultrasound or mammo. That could come up later, maybe, okay? But it's the best way to do lesion size. So let me give you an example. Here's a patient who has got this palpable BB on here, and you can see she's got dense breasts, but there's really nothing abnormal about the mammogram. Otherwise, looks pretty normal. But because she's got the palpable complaint, we take her to ultrasound, and you can see we find a 1.3 centimeter lesion. And if you look at the surrounding tissue, it looks pretty normal, right? She's got an axillary node with asymmetrically thickened cortex, and so we stuck a needle in both of those, and we got invasive ductal carcinoma metastatic to the node. So we're busy congratulating ourselves on making an accurate diagnosis, but then she goes to MRI, and you can see the clip here, and I don't even have to put a scale on this for you to realize that that's way bigger than 1.3, right? I mean, here's another scan just a little bit further down, and another step. Oh, let's just go ahead and look at the MIP, and you can see how much disease she has. It's really 2 quadrants of the breast, maybe 3. So there's much more disease than we suspected on conventional imaging. So MR is best at lesion size. It also finds tumors that are mammographically and sonographically occult. Here's a lady who has very, very dense breasts. She's got a complicated breast pattern. These are the T2s with fat suppression. You can see she has multiple masses, both sides, lots of inflamed cysts. Very confusing mammographic picture. She had some mild distortion in the right 4 o'clock position. Here's the tumor that we found on ultrasound. And this is the gadolinium enhanced with subtraction, showing the dominant tumor at right 4 o'clock. What was unsuspected was an additional tumor, which is presented as non-mass enhancement in the right 10 o'clock position. So this lady has multicentric disease, first discovered at MRI. And of course, we can go back with ultrasound and find this with targeted ultrasound. Maybe it would have been found with ultrasound screening, but really, the MR is what's showing this tumor to us. This lady had mammographically a single tumor and a fatty breast in the central breast, just calcifications. But when we give gadolinium, you see this cobblestone appearance, this clumped non-mass enhancement extending to and including the nipple. So much more disease than suspected on conventional imaging in this case. Additional lesions are seen in about 16 to 20% of patients based on historical meta-analyses. And these are 2 of the biggest meta-analyses. The most recent is from Plana from Europe from 2012, including 50 studies showing additional lesions are present in about 20%. These numbers have gone up over time, though, as we have improved MR technique and MR biopsy. And this is additional lesions, not additional malignancies. Both of these meta-analyses had a positive predictive value for the MR findings of about 67%. All right, in addition to finding tumors in patients who have a diagnosis, a special case of finding mammographically or sonographically occult lesions is the search for primary. And here's an example of that, a lady with a very dense breast. She presents with an enlarged axillary node. I know you've all seen this scenario. We biopsy the node and it's malignant. The question is, where is the tumor? And MR is perfect for this. You can see the node here. She's got, this is the sagittal projection, and there's the node. And then here in this, close to the chest wall, in approximately the 3 o'clock position of the left breast is the tumor, not seen because of the dense tissue. Here's a case of the same type of evaluation. This was an outside case that came to us for MR. So these are outside mammograms. The patient presented with an enlarged left axillary node. You can see she has dense breasts, but otherwise, it looks pretty normal. It looks normal on the cranial caudal projection as well. So there was no suspicion of the tumor based on conventional imaging. They went ahead and excised the node. That's not ideal in our practice, we would just put a needle in it and make a diagnosis that way, but they didn't have that available. So they excised the node and found it to be positive for metastatic breast cancer, and that's how she came to us for MR. So you can see on this scan that she has axillary adenopathy. She has actually quite abundant axillary adenopathy, a number of nodes. She's got a lot of edema in the breast, probably partially because of the difficulty draining the breast at this point, but also some post-operative edema because she has been operated on. And here is the T1 non-fat sat, which I like this pulse sequence for anatomy. It's very good for basic anatomy, looking at skin thickening, things like that. You can see the tissue looks normal until we dump the gadolinium in, and there you can see the tumor, which we were able to then find with targeted ultrasound and biopsy, and that was her invasive ductal carcinoma. And one more case, this was a good example of how important the technologists are and what we do as breast imagers. So this patient was very stiff and had difficulty moving her arms, so the tech was having a hard time getting pectoralis muscle in. So you can see she's just barely heterogeneously dense. She got fairly good pec on this side, not optimal, but on the right she really just couldn't get it. So she really pulled her in, and this is what popped out. So she's got an enlarged axillary node on that side. The rest of the breast, though, looked pretty normal.